All right, I'd say good afternoon for everybody, and thanks for attending this talk. Today we will have a talk by Dr. Mohamed Rafaat. He's a highly experienced vascular and endovascular surgeon in Al Zahra Hospital. He will take us to a talk about the rising to the challenge of managing acute and extended VTE treatment. And this is, in fact, especially the extended treatment is a quite interesting talk these days. So Dr. Mohamed Rafaat, the floor is yours, and you can start right now.
Thank you so much, Dr. Mohamed Yusuf, for the introduction. Thank you, the honorable audience, for attending, and the panelists and the Emirates Society of Internal Medicine. So I'll just start sharing my screen now so that we can all see it. And then here we go. Just checking that you can see my screen.
Yes, sure.
Okay, so we'll call this quick presentation more of a discussion, I hope. Venous thromboembolism patient's journey. It's a comprehensive protection-based and treat and extend approach. Patients with venous thromboembolism need to be treated in the acute phase, and it has been shown that with many of the recent studies, we need to also decide whether these patients would need to have an extended protection so that we can prevent a recurrence of the venous thromboembolism event that has happened. So this is a picture of a gentleman that we might commonly face. It's a clinical scenario, a 67-year-old gentleman. He's a bit obese, and he suffered from pulmonary embolism after a recent flight, a long-haul flight, which is, again, a common scenario. What he worries about is that he didn't know that pulmonary embolism could be fatal. And of course, once he hears that he has pulmonary embolism, he'll feel that he's totally out of control of the situation. What do we know? We know that as doctors, we know that patients that suffer from unprovoked and non-surgical provoked venous thromboembolism experience a higher risk of recurrence after treatment cessation. And we roughly know that the risk of recurrence at 2 years is a cumulative risk of approximately 20% in patients with unknown cause and 8% in patients with non-surgical causes. Trying to translate this, the previous slide, and to understand this slide just explains to us with the meta-analysis that was done over 18 studies over a sum of almost 7,500 patients, the incidence of recurrent venous thromboembolism per year was highest, of course, at the first year, where it was approximately 10%. And of course, it decreases as time passes by. But the cumulative incidence of recurrent DVT is somewhere around almost 16% at the first 2 years. So what do we say? We say that patients at high risk of recurrent DVT after discontinuing anticoagulation. We know that anticoagulation would effectively resolve venous thromboembolism when we're treating it with it. But stopping the treatment does increase the cumulative risk of venous thromboembolism recurrence. And we know that the cumulative incidence of recurrent venous thromboembolism goes somewhere approximately 10% in the first year if the anticoagulation is stopped. Now, just to make sure we set grounds what we're talking about when we stop anticoagulation after the first therapeutic duration, which we will go through later in this presentation. We're talking about a treatment duration of somewhere between 6 to 12 months of proper anticoagulation. Now, we're going to talk about NOACs, and we know that NOACs are well suited for extended treatment because they do not require injections, so they're quite convenient and patients will be probably compliant with them. They do not need any routine coagulation monitoring and blood testing and sampling and INR because they do not require a monitoring test, and they have very few known drug-to-drug or food-to-drug interactions. So again, to explain more what we are talking about, we're talking about patients who suffered a venous thromboembolism that have a high risk of recurrence. The recurrence rate was higher highest in patients who have unprovoked DVT and we stopped their anticoagulation. Patients that had a provoked DVT by non-surgical risk factor were again higher than others, but less than the unprovoked. And the patients who had a solid provoked surgery that caused the DVT were at the least risk of recurrence. So I would say that the patients would rely on our skills as physicians on deciding which one would need to be on an extended treatment and which one would need just enough therapeutic treatment for the first 6 to 12 months. This is just a graph that would give us a quick idea that the cumulative incidence of recurrence rate when compared when we use Rivaroxaban as a NOAC and aspirin and placebo at different categories of patients. We see that the highest rate of recurrence was, of course, with the unprovoked venous thromboembolism. Whether we're using placebo, aspirin, or Rivaroxaban, of course, it was higher, but from the graph, we can easily see that definitely it was lower in the graphs that were in the patients that were receiving an anticoagulant. Now, why are we talking about Rivaroxaban in particular? Because Rivaroxaban has actually been tested in a broad range of studies in the patients that required venous protection and in the patients that required treatment. We have a wide range of studies. The patients that were the studies that were done on Rivaroxaban for treatment of patients with venous thromboembolism had a total number of somewhere around 10,000 patients, while the patients that were treated with Rivaroxaban for prevention of venous thromboembolism, the studies go to around 31,000 something patients. We're going to talk more about the venous thromboembolism studies because over there were other studies where we studied the extension and the choice. They're called the Einstein extension and the Einstein choice, which will tell us more about why should we or should we not extend the treatment for patients. So let's take just a quick walk through the evidence for Rivaroxaban in management of venous thromboembolism patients. We will talk about the standard method of treatment that we treat with venous thromboembolism as the low molecular weight heparin that was followed by a vitamin K antagonist. And the low molecular weight heparin was an injectable, the vitamin K antagonist was an oral medication. We all know about that. There are a lot of interactions that happen with vitamin K antagonists, but still it was the mainstay of treatment of venous thromboembolism. It's still a very effective medication. It's a very effective method of treatment. No one's saying anything wrong with it, but we're saying that we have alternatives that might offer us the same good efficacy of the standard treatment, yet give us less risks. So on the graph on the left-hand side, we could see that the rate of recurrence with venous thromboembolism for patients over the same amount of time showed that there is almost similar efficacy in preventing the cumulative event of recurrent venous thromboembolism whenever we are using the standard or the low molecular weight heparin followed by vitamin K antagonists, and whenever we are using the NOACs such as Rivaroxaban. And the number of patients that were compared are quite similar, almost 4,130 patients with 4,150 patients. So these are quite large numbers that are comparable, and it tells us that there is a non-inferiority at all whenever we are comparing Rivaroxaban as a monotherapy in treatment of venous thromboembolism to prevent its recurrence in comparison with low molecular weight heparins and vitamin K. On the other graph, we see the major bleeding events. And we know that we are using anticoagulants, which means that blood is thinner simply, so the patients are more likely to bleed. Again, the comparison is the monotherapy using the Rivaroxaban versus the low molecular weight heparin vitamin K antagonist. And we do see that there is a relative risk reduction of 46% and an absolute risk reduction of 0.8% in cases of major bleeding. This means that we have a tip on the scale now that makes us handling patients a bit more safer than our usual standard treatment because there is a less likely chance of major bleeding. This was extrapolated from the Einstein DVT pulmonary embolism study. Now, we'll just say a quick thing about the management of pulmonary embolism in the acute phase, where NOACs are recommended as the first choice for anticoagulation treatment in eligible patients. Vitamin K antagonists are an alternative to NOACs. These are enhanced with class 1A and C evidences that tell us that initiation of anticoagulation is recommended without delay in patients with a high or intermediate clinical probability of pulmonary embolism, even until we get the diagnostic workup done. And when oral anticoagulation is started in a patient with pulmonary embolism who is eligible for a NOAC, then a NOAC is preferred than vitamin K antagonists. We'll talk now a bit more about the Rivaroxaban versus placebo efficacy and safety in extended venous thromboembolism treatment. So the incidence of recurrent venous thromboembolism versus major bleeding. On the y-axis, we have the incidence in percent, and we could see that the gray graph, or the gray diagram, will represent the placebo, while the blue will represent the Rivaroxaban. Definitely, we could very easily see with confidence that there was a much reduced risk than placebo, which is logical, when using Rivaroxaban to decrease the recurrence of venous thromboembolism. But the nice thing that we will see is that the incidence of major bleeding when comparing Rivaroxaban to placebo was quite comparable, which means that we are safe. We probably do not have that much of a high risk of bleeding. So to reinforce what we just said, we'll just take a bit deeper look into what's called the Einstein Choice Study. And the Einstein Choice Study was mainly composed of 3 arms, without going into further details of studies and explaining what they mean. But the objective of the study was to compare efficacy and safety of once daily dose Rivaroxaban, whether the 20 milligrams or the 10 milligrams, with aspirin 100 milligrams once daily in venous thromboembolism patients who have completed the initial treatment phase. We said that the initial treatment phase usually lasts between 6 to 12 months of treatment, with equipoise regarding the need for extended anticoagulation. This study comprised almost 3,400 patients, and each arm of the 3 arms had a similar, almost similar number of patients. Arm 1 would have patients receiving 20 milligrams once daily. Arm 2 would have patients receiving 10 milligrams once daily. And Arm 3 would have aspirin receiving aspirin 100 milligrams once daily. The treatment duration was 1 year after the therapeutic duration. So we're talking about 6 to 12 months of the initial treatment for the symptoms, then extending the treatment for 1 year duration with any of these 3 methods. As I mentioned, it's a very delicate scale. We do not want to tip the balance of the scale to any side. We do not want a higher risk of bleeding. At the same time, we do not want to risk the patient suffering from another attack, because venous thromboembolism is devastating. It does cause a lot of problems to the patient, to the healthcare system, and on the personal level, to the families and to the work happening. So do we need extended anticoagulation or no? The rationale for the study arms, why did they choose Rivaroxaban 20 milligrams, 10 milligrams, and aspirin 100 milligrams in the Einstein Choice Study? So we have enough data telling us that the Rivaroxaban 20 milligrams once daily does reduce the risk of recurrent thromboembolism by 82% compared to placebo. So it's doing a good job. We have enough studies telling us that Rivaroxaban 10 milligrams once daily offered is an effective thromboprophylaxis after most elective hip or knee arthroplasties. So again, it does a good job in prevention. And we know that aspirin 100 milligrams once daily has been shown to reduce the risk of recurrent venous thromboembolism by more than 30% compared with placebos. without increasing the risk of major bleeding. So we are comparing three supposedly effective methods of preventing venous thromboembolism. So we're going to talk now about these, the graphs and the results that are extrapolated from the Einstein choice. Both Rivaroxaban doses did show superior reduction in the rate of recurrent venous thromboembolism rates compared to aspirin. So we can see, yes, that the cumulative incidence of venous thromboembolism over a period of 1 year was less with using either dose of the Rivaroxaban, whether the 10 milligrams or the 20 milligrams once daily. The aspirin, the use of aspirin 100 milligrams once daily was not able to effectively decrease the cumulative incidence of venous thromboembolism recurrence as any of the Rivaroxaban doses did. So this means that we have better prevention, but does that mean that we have less bleeding? So this graph tells us that over a period of 1 year, the patients receiving the aspirin and the two different doses of Rivaroxaban had almost a similar or an equal rate of incidence of major vascular bleed, major bleeding. So what we get from here is knowing that from the previous slide, we have monotherapy that has a better effect in prevention, and from this slide, that this monotherapy does have a comparable rate in major incidence of bleeding to the aspirin. So did both Rivaroxaban doses reduce venous thromboembolism versus aspirin in a broad spectrum of patients? Yes, whether the 20 milligrams or the 10 milligrams Rivaroxaban have better results than the aspirin alone as a monotherapy. And why are we talking about as a monotherapy? Because if you're going to tell a patient, continue on a medication for another year, even though we have finished the initial treatment, you need to give him the simplest medication that he'll probably be more compliant with. So when comparing these doses in decreasing the rate of venous thromboembolism recurrence, both doses showed to be more effective than aspirin. And when comparing major incidence of major bleeding rates, we'll find that they were rather similar across the different patient subgroups, and whether using the 20 milligrams, the 10 milligrams, or the aspirin. So the risk of bleeding is similar, and we have better prevention with NOACs than with aspirin alone. So let's put this into more scientific talk. What do recent guidelines from respected scientific bodies recommend regarding classifying the patients, their risk, and how do we extend management for venous thromboembolism? So this is a tough slide, but actually everything revolves around it. This is the categorization of risk factors for venous thromboembolism based on the risk of recurrence over long term. So when we say that this patient is a low risk or intermediate risk or high risk, we are talking about risk of recurrence. This is not risk of developing a DVT. We already know that these patients have suffered from venous thromboembolism. We're talking about the risk of recurrence. When we say that the patient is at a low risk of recurrence, this means that he probably has some major transient or reversible factor that was associated with an increased risk of venous thromboembolic events. Simply, he had a surgery, required general anesthesia for more than 30 minutes, and he earlier had a venous thromboembolism. He's a bedridden patient for more than 3 days, trauma with fractures, and he probably won't be able to move. An intermediate risk patient is a patient who has a transient or reversible risk factor. He must be not a cancer patient or a non-identifiable risk factor. Such intermediate patients at intermediate risk of recurrence may be patients going to minor surgeries, patients who have a physiological state that's causing them to be of a hypercoagulable state, such as pregnancy, women on estrogen therapy or receiving oral contraception pills, all of long-haul flights. These patients are at an intermediate risk of recurrence. Again, we're talking about recurrence. This means that all of these patients previously had an attack of venous thromboembolism, and now we are assessing, should we give them an extended treatment or no? Now, the high-risk patients, high risk of recurrence, of course, are patients who have active cancer, patients who have had one or more previous episodes of venous thromboembolism in the absence of a major transient or reversible factor, and patients with persistent, strong hypercoagulable states such as antiphospholipid antibody. Cancer is a very separate entity. We should always look at it alone. And whenever we have patients who have malignancy and suffered from venous thromboembolism, we should study quite well. Should we stop or should we continue? Because in other studies, it showed that the first presentation of a lot of malignancies was DVT of somehow. To summarize the previous study, we could just say that we'd go for low risk, intermediate risk, high risk, and this was the European Society of Cardiology telling us that for low risk patients, they wouldn't that much go for extending treatment. For intermediate and for high risk patients, they would definitely consider, and we're talking about consider, they wouldn't say you must, but you should consider the idea of an extended treatment. And this will be applied to the doses that we have and how to extend the treatment. So when we're talking protection for patients means that we want to prevent another devastating recurrence without increasing the risk of major bleed. We want to prevent recurrence and we do not want to have a major bleed. Recurrence is defined as another attack of venous thromboembolism after finishing the initial phase of treatment. What we see is that the difference in the cumulative 1 year incidence of major bleeding, when we're talking about Rivaroxaban versus Aspirin and Rivaroxaban versus placebo, they're quite, they're rather similar, which means that we do not have a higher risk of bleeding.
Dr. Mohamed, can we, you have 1 minute to finish, please, because it's already over time.
Sorry, I'm almost done. So just to summarize, we have similar major bleeding rates with Rivaroxaban and versus placebo or versus aspirin. I won't go into these because they're quite difficult. These are the 2019 European Society of Cardiology guidelines, and they do recommend to go for extended treatment. Just to summarize all of this, Rivaroxaban treatment can be used as a monotherapy from the beginning till the end. Whenever you have a patient with acute, you can start with your regular dosing, 15 milligrams BID, 21 days, continue for a full therapeutic dose of 20 milligrams, somewhere between 6 to 12 months. And according to the risk factors for recurrence, you could either decide discontinue treatment, give a patient 10 milligram once daily if he's an intermediate risk of recurrence, or 20 milligram once daily if you think that he's at high risk of recurrence. We're specifically talking about cancer patients or patients who have a persistent, strong hypercoagulable state. So we could tell our patient that according to the clinical scenario that we had, according to his condition, we would consider a reduced dose of 10 milligrams anticoagulation after the first 6 months of treatment. Thank you, and I hope I didn't take so much of your time.
10 minutes.
Thank you very much, Dr. Mohamed, for this quite elegant talk. And I just want to ask you a simple question. When we say extend treatment, extend for how long?
The extension study encompassed 1 year. So all the study that we're talking about, the Einstein extension, composed 1 year after completing the initial phase of therapeutic treatment. Now, we do not have more data about lifetime anticoagulants, but we as practitioners and as doctors, we already do that for patients who have high risks of venous thromboembolism and have already suffered one. We do extend their therapeutic duration for quite longer times. But when we're talking about solid data, the Einstein extension the choice labeled 1 year after completing the therapeutic dose.
Even people with the high risk of recurrence?
This is what I just said, that we do, the data and the guidelines from the European Society of Cardiology, we're talking about 1 year, but patients with high risk of recurrence, this wasn't a slide that I wanted to show, unfortunately, but we were lacking time, that there is level 1B evidence saying that oral anticoagulation treatment of indefinite duration.
Indefinite, all right,
yes,
this is what I want to hear.
Is recommended for patients high risk.
We have plenty of patients who should go for indefinite treatment, and
yes,
probably they are undertreated.
Yes,
you
definitely.
agree? All right.
I agree that DVT or venous thromboembolism is still extremely undertreated.
All right. Okay. Right now, we will give the chance for audience if they have any question to Dr. Mohamed. All right. Any question? Okay, we have different NOACs, dabigatran, Edoxaban, Rivaroxaban, Aspirin, and So now one of the edge of advantages of Rivaroxaban is being once a day. Okay, right now. If you have a patient who has thromboembolic problem and he has chronic renal disease, which one you will choose among these NOACs or DOACs?
Well, we're starting to put very specific subgroups. We know still that specific subgroups need adjustments. I would rather go with low molecular weight heparin still, or even unfractionated heparin in patients suffering from acute kidney failure or patients on dialysis until they pass the first.
No, I'm not talking about dialysis. Of course, when we say chronic kidney disease,
yep.
There are stages for the chronic kidney disease. Stage 1, 2, 3, and 4, and stuff like that. And it ends by the end stage renal disease, the patients on dialysis. I'm talking about patients with the chronic kidney disease. Of course, if patients have estimated GFR less than 30, then, we are close to the dialysis patients, okay? I'm talking about patients who are above this level. Say, chronic kidney disease, yeah, okay.
Get your point. So as long as we're not yet on dialysis, we could still consider using the almost the normal dosing for the NOACs in treatment venous thromboembolism. So I would still rather say, to be quite honest, any of the anti-factor 10s, the Zabans, or the dabigatran, which is specifically against thrombin, can be used as long as we are not yet in the dialysis area with no need for specific dose adjustments.
So when it comes to the renal excretion of the NOACs, 80% of the dabigatran is excreted by the kidney, and 50% for the Edoxaban, 33% of Rivaroxaban, and close to 25 to 27% for Aspirin. So probably the last two, Rivaroxaban and Aspirin, probably they are better. And when we say, especially for the extension, you showed slides showing that there is no much difference between the 20 milligram and the 10 milligram of Rivaroxaban for extension.
Doctor.
So if our patient have chronic kidney disease, we can go safely with the 10 milligram.
Doctor, sorry, with all permission due, we have another topic that is running, and we have exceeded our time. Thank you very much for your presentation.
All right.
And for the discussion that you had. Thank you very much.
Thank you very much. Thank you.
Thank you, everyone. Thank you for the valuable information, Dr. Yusuf. Thank you.
Thank you, Dr. Mohamed. Nice meeting you. All right. Thank you. Goodbye. Bye-bye.